All right, let's go over the oxygen delivery systems. We'll go over each one, and I'm going to make you an expert with all these. So the first one is a cannula. Now, this is something that we all use, but let's make sure that we're experts on this. First thing we're going to do is and they are going to point down into the nares. Okay. Now the liter flow for this is 1 to 6 liters. Now I want to put myself on 2 liters. Let's actually go 6 liters. Wow, and this is something. Now, if you've never been on oxygen before, it's not that comfortable. It's really cold. I can smell plastic because of the oxygen. So we have a titrate order now of what? 92% and up. Maybe even lower for COPD or 80 and up. It's not like the old days where they had to be 99, 98% and up. So let's look at that. We'll also ask our patient, are they on home O2? Are they using oxygen? So whatever they're on, we're kind of going to leave them on whatever they use at home. If you're in a situation where you're able to provide humidity, we'll try to humidify this if we're going above 4 liters and up, because this kind of dries it out. And we'll use this bubbler. The bubbler picture there, if you're familiar with this is only to be used for nasal cannulas. You'll see this used with other things, but it only works to 6 liters. And same thing with the cannula, it only works up to 6 liters. Now, you can't turn it higher, but the physics of the tubing doesn't allow it for it to oxygenate properly. When we're intubating, we'll sometimes put a patient on 15 liters, but that patient is not actually breathing. It's apneic ventilation. Okay. So let's say that they need to go on something else. They're not doing well. They have to go on BiPAP or they have to get on a vent. How much oxygen are they going to need? So let's say they're doing just fine on 6 liters, set about 98%, and for some reason or other they have to go on a vent or they have to go on BiPAP. How much oxygen are we're going to put them on? So based on this 6 liters, we're going to have to convert it to FiO2. And how do we do that? There's a simple formula. Let's go over that. Here it is. You may have learned it a long time ago, but it's a good idea to just apply this every time that you put someone on a device that has air entrainment involved. So we're going to take liter flow, we're going to times it by 4. 4 being the magic number. I can't tell you why we use it. It's just that's the number we use. And we're going to add it to 20. And 20 represents the amount of oxygen in the room. And typically it's about 21%, but we're going to round down because these aren't very precise instruments. Okay? So liter flow times 4 plus 20, and that's how we get our FiO2. So if we look at our example at the bottom, if I was on 6 liters, we'd take 6 times 4 equals 24, 24 plus 20, and that equals 44%. And that is when we put our patient on our BiPAP or we intubate them, we're gonna kind of stick to the same oxygen. Okay. So let's go over another mask. Now this mask is probably not very common anymore. It's more of an older school type thing, but it's very important because it's still in use. And I'm going to show you this because you may come across this, and it's important to know how to use this. Okay. So I'm going to put this mask on. And so this patient, I'm a patient who was a mouth breather. Okay, so I wasn't doing it very well on my nasal cannula. So someone grabs for this, they put it on me. And I want you to notice what's going on with this mask if you can see it. You notice that it's fogging up. Okay, why is that? Because I have to run this at least 5 liters to wash out that CO2. On your oxygen tank, you actually don't have a 5, so 6 liters is fine. So 6 liters, and that will have to wash out the CO2. Now the problem with that, with using this mask, is not everyone knows that. Okay? And it doesn't say anywhere on the literature. It doesn't say run this at 5 liters and up. Okay? That would be nice if it did. So there's a lot of people using this wrong. Okay? And so you don't want to retain CO2 necessarily. So if you have a mask like this, I would recommend not using it because you may know how to use this, but the next person won't. I see that a lot of people wearing this on 2 liters, coming back from places, and they're basically just retaining CO2. This mask also isn't a great mask to take apart and use for breathing treatments, and I'm going to show you why. I'm going to show you how the breathing treatment masks work and how this isn't quite the same. Okay? Now the next mask we have is great because it takes away the need for the simple mask, and it also is pretty dummy proof. You can't really mess up with this. Okay? So we have our oxy mask, and I'm going to go ahead and run this at 15 liters. So at 15 liters, this is fairly comfortable. Okay? I could barely talk when I have that 6-liter cannula on, but I'm getting 15 liters of oxygen, and I feel good. Yeah. It's a little bit cold, but I'm getting humidity because there's humidity in the room. Okay? So you don't have to humidify this mask. In fact, there's not really a way to. If you use, like I said, if you use that bubbler they use for the nasal cannula, it doesn't work. It doesn't work past 6 liters. Okay? This mask, though, you could run from 1 to 15 liters. And the FiO2, for this, it tops out about 95%. There's a little cheat sheet on here that does the math. Kind of tells you what you're working with. Now, this mask is very comfortable. It's not as claustrophobic. I could also give a breathing treatment over this. So there's a lot of good things about this mask. The only drawback about this mask is it's fairly expensive. This mask is about $4 to $5, whereas this mask is probably 75 cents. Okay? So this is a very good mask, and hopefully we won't be limited by the price, but I'm seeing a lot of these out there. Okay? It's a very good mask, very versatile. Non-rebreather. Okay. So our non-rebreather, this is our mask when we mean business. Okay, our patient needs oxygen now. Okay. So let's hook this one up. Now, what's our liter flow for this mask? And I'm going to wait till it fills, okay, because the way that this works is we have a one-way valve on the mask, and whatever we're breathing is in the valve. So, if there's nothing in the bag, I'm not breathing anything yet. Okay? You don't put it on your mask. Well, it's not a very comfortable mask, but this gets it done. We're going to get about 100%. Closest you could get to 100% with this mask. But how are we going to run it? What is our liter flow? What's the minimum you could run this mask without causing damage? So the minimum, as you can see, is 6 liters. Okay? That doesn't mean that we're going to run it at 6 liters. It just means that on the ambulance, you don't have a lot of room for equipment. So you have nasal cannula, which goes from 1 to 6, and then non-rebreather, which goes from 6 to 15. It kind of picks up where this leaves off. The only problem with using it 6 liters, 7 liters, 8 liters is we don't know the FiO2. Okay, we can't do that same formula because there's no room air entrainment. We're not in training room air, so we can't do that formula. We have to look at the bag, and if it's filled, we know that we're getting oxygen. Okay, so the best way to gauge if they're getting the 100% that we want to give them is to run it at 15 liters. Okay, so whenever we run this, we want to run it at 15 liters. Of course, if you're limited with equipment and they don't necessarily need this much oxygen, feel free to run this lower. But just know that we're not getting a precise oxygen in the FiO2. Okay? So 100%, 15 liters. If you have other equipment and you can wean them, put this on the wean because you can kind of titrate this down and you can be more accurate. We want to be accurate with this drug. Oxygen is a drug. We want to have some accuracy. You're not going to give them just a smidge of insulin, right? So oxygen, you got to think of it as a titratable drug that we need to keep an eye on and chart. Oxygen duration is pretty important when you're transporting patients. So we're going to go over a math problem to show you how to calculate that. There's a bunch of apps out there that will do it for you. But this is this old school way to go over it. So what we're going to do is we're going to take the PSI in the cylinder. And we have safe residual pressure, 200 that we may subtract. Based on our policy, just to stay on the safe side. We may or may not do this. But we'll take that, we'll times that by the tank factor. Now, we're using the M tanks on our Falck rigs. So we're going to look at our chart, and we have M cylinder factor, 1.56 liters per square inch, PSI. So we're going to take that, and we're going to divide that by the liter flow that we're going to give our patient. So here we have a M cylinder that has 2,000 PSI in it. We're going to times it by the tank factor at 1.56. That'll give us 3120, and then we're going to take that and we're going to divide it by the liter flow. And that'll give us 780 minutes. And then if we want to break it down into hours, divide it by 60, and we get 13 hours of oxygen on 2 liters with an M tank that has 2,000 PSI in it. That's how we do that. But my quick way to do this is to get an app or just have extra tanks. All right, let's go over breathing treatments. Now, we have our neb kit, and in our neb kit we have tubing, we have reservoir, we have mouthpiece, we have a T-piece, and we also have the medicine cup. Now, the thing about this, okay, is every part of this is important. Okay? We don't want to assemble this and leave out a part. Like, for instance, I've seen people just put this together without the reservoir tubing. And I'll explain more about the reservoir tubing and why it's important. Okay. So we have our neb. And what is our liter flow for a neb that we're going to run it at? Okay. I hear a lot of this to this, between this and this, 6 to 10, whatever. It's one thing, 8 liters. Okay. And why is it 8 liters? Because science. Because we have to make a micron that is small enough to go to the lowest part of the lungs. So if we run it at 8 liters, they have determined that that gives us a micron of 5 microns. Okay? And that's small enough to get to the lowest part. If we run it lower than 8 liters, they're not as big. If we run it faster, we're wasting the medication because it's going too fast. Okay? This is the least efficient way to give a medication. This bullet that we give is 3 times the dose that we give. Okay? Why are we giving so much? Because this is technique-based. Okay? Our patient has to do this properly to get the right deposition to the lungs. That's how they have to do the treatment. Keep the lips on the neb, breathe all the way through. Now, if we don't have this, we're wasting about 30% of the medication because it's not recirculating. We need this to recirculate because we are breathing, we are inhaling. Okay? So don't make this without this. The best technique is nice and slow. Now, if we have a patient who doesn't have the dexterity, and they're not doing this properly, we're going to use a mask. It's also important to note that your oxygen tank here has an 8 on it. Okay? And why? Because it's used for breathing treatments. Okay? Now, if we have a patient who's not doing their technique properly, it's perfectly okay to put on a aero mask. Now, given a choice, what's more effective? This or this? If with proper technique, this is more effective because it's going right into the airways. This, it's kind of circulating in front of them, and they have to just inhale it. Okay. so a lot of it is getting wasted where you're getting stuck in the upper airway. Okay, so we need to get it down to the lung. Okay? But this, between this and this, if this is poor technique, and this is not, this is more effective. Okay. Now, NEPs for kiddos. I've seen different ways of people doing blow-by. And I've seen this technique where I've seen someone tape this and they give the neb, and I think all that does is waste medicine. Okay? Because why are we putting medication on the forehead? We want to kind of put it in one spot, put it by the mouth while they're inhaling. So what I do is I keep the plastic that comes with it, and I'll just occlude one end of it and give the blow-by this way. Okay. You can also use a glove or whatever, but you want to get this around where they're inhaling so you get it. Yeah. And this is a spacer, and this is our inhaler. Now, the reason why I'm going to show you this with a spacer is because a spacer is about 75 to 85% more effective than without. Okay, you'll see patients huffing this on. They come in the ER and they've been hitting this all day. It's not working. Well, because your airways are tight and it's not getting anywhere. Okay? So the way that this has to be given is nice and slow. And that's what the spacer does. So how we give it is we shake it, breathe out completely, hit the medication, slowly inhale. Now, if we inhale too fast, you'll hear this kind of warning whistle. And that's what we don't want. And you'll actually see on the spacer that there's a musical note with a cross over it, like it's what's pictured there. Okay? It's a warning whistle. So make sure that your patient is not doing this to the whistle, because usually whistle is a reward system, and this is not. I've heard doctors and nurses and RTs say, do it till you hear the whistle, which is absolutely not true. So don't tell them to go to the whistle. There is, however, on the market, they just came out with another spacer that does have a whistle that's a positive thing, so which is a mistake. We shouldn't get into this thing. But just to make sure, using the right spacer, look at it. If this is the non-whistle one, you make sure don't go to the whistle, because it's very important that they're doing it properly. Okay. There's other spacers out there. It's made for children, has a mask on it, and these are good for patients who can't coordinate that inhalation. Because what you do is you put it on their face, and eventually they're going to breathe, and when they do, they're going to get that treatment. So these are our spacers. Dry powder inhalers. Now, as a transport nurse or EMT or medic, you may not be anywhere near these. You might have to use it, but it's still a good idea to know how they work. Because you'll have patients who have them and they're doing them and they're administering them. So it's always good to have this knowledge. And the thing about dry powder inhalers, the only difference is you have to do it fast and deep. It's not an aerosol. Okay, it's a pill that gets crushed and you inhale this dust and that gets to your lungs. And you have to do that fast and deep. Okay, it's a lot different than a MDI. And so with all DPIs, they have to rinse because you don't want this medication to be in the upper airway. But it's different. Fast and deep, the MDIs are nice and slow.